Hi and welcome to the E-Module training for primary care medical officers in Selangor. This module is created to guide you in managing diabetes in pregnancy. The narrating voice summarizes the slide presentation. Feel free to click pause if you need more time to read the slides. The outline of the module includes defining diabetes in pregnancy, screening and diagnosis, and the details in managing GDM. Now we start with the basics, the definition and classification of gestational diabetes mellitus or GDM. GDM is defined as a state of carbohydrate intolerance which results in hyperglycemia of variable severity. An important point is its onset or first recognition is noted during pregnancy and resolves within the puerperium period. This holds true to many patients that we see every day in the clinic. The moment the patient has delivered, her blood glucose will soon normalize, isn't it? As far as classification is concerned, pregnant women complicated with diabetes can be classified as pre-existing diabetes and gestational diabetes. Now we talk about screening and diagnosis of diabetes in pregnancy. Who are at risk to develop GDM? We need to screen for GDM if the patient has any of the following risk factors: BMI more than 27 kg per meter square, previous history of GDM, first degree relative with diabetes mellitus, history of macrosomia, that is more than 4 kilograms, bad obstetric history, for example, unexplained intrauterine death, congenital anomalies, and also history of shoulder dystocia, presence of glycosuria equal or more than 2 plus on 2 occasions during current pregnancy, and finally, obstetric problems during current pregnancy, which include essential hypertension, pregnancy-induced hypertension, polyhydramnios, and current use of corticosteroids. Why and how the screening process is done. We do routine screening to identify asymptomatic patients who may have overt diabetes or GDM. The test that is used is Modified Oral Glucose Tolerance Test, or MOGTT. MOGTT should be done at booking for high-risk women and repeated at 24 to 28 weeks of gestation if the initial result was negative. For all women with the age equal or more than 25 years old with no risk factors, MOGTT should be done at 24 to 28 weeks of gestation. What about the diagnosis of GDM? As we know, MOGTT has been recommended by international guidelines. On the other hand, we do not rely on HbA1c for screening purpose, as HbA1c alone is not useful as a diagnostic test for GDM. Apart from HbA1c, random blood glucose measurement is also inadequate to screen for GDM. Now, getting familiar with following values is very important in diagnosing GDM. We diagnose GDM in the presence of any one of these results. When fasting plasma glucose is equal or more than 5.1 millimole per liter, or when the 2-hour postprandial value is equal or more than 7.8 millimole per liter. What is overt diabetes in pregnancy? There is no universally accepted definition of this condition, but overt diabetes is suspected in the presence of at least one of the following, especially in the first trimester. It is when fasting plasma glucose is equal or more than 7 millimole per liter, and when random plasma glucose is equal or more than 11.1 millimole per liter with the presence of hyperglycemic symptoms. The diagnosis of overt diabetes is sometimes confirmed with a second test using either fasting or random plasma glucose or MOGTT. This largely depends on the local practice. If the results are suggestive of overt diabetes, treatment and follow-up should be carried out as for pre-existing diabetes. This slide shows the flow of algorithm for screening and diagnosis in pregnancy. The algorithm on your left shows the flow of screening, that is, identifying risk factors of GDM and performing the 75-gram oral glucose tolerance test. Subsequently, following the cutoff values, GDM is either diagnosed or the OGTT is repeated at 24 to 28 weeks of gestation. If at this point the value is still negative, then only we can exclude GDM. The table on the right shows values of blood glucose when overt diabetes is suspected and risk factors which alert us to screen for diabetes in pregnancy. Now we move on to the topic of antenatal management of diabetes in pregnancy. First, we discuss about pharmacotherapy in diabetes in pregnancy. Oral antidiabetic agents, or OAD, are frequently used in the treatment of GDM. Metformin and glibenclamide have been used in GDM. The FDA pregnancy category for metformin is category B. On the other hand, glibenclamide falls into category C. In clinical practice, we currently use metformin as the only OAD in GDM. Category B of a drug means when the animal studies of the drug have failed to demonstrate a risk to the fetus and there are no adequate and well-controlled studies in pregnant women. On the other hand, Category C means when animal studies have shown an adverse effect on the fetus, and adequate and well-controlled studies in humans were not available. Let's look into what does the meta-analysis show regarding OADs in GDM. For those who are unfamiliar, meta-analysis is a statistical analysis that combines results of multiple scientific studies. Meta-analysis reviews multiple studies across the same subject area. This type of study design sits at the top in terms of hierarchy of evidence. So, how does the oral antidiabetic drug fare according to the studies? In one meta-analysis, metformin versus glibenclamide showed metformin had significantly lower rate of maternal weight gain, neonatal birth weight, macrosomia, and large for gestational age. However, between these two drugs, there was no significant difference in glycemic control, caesarean section, preterm birth, stillbirth, and neonatal hypoglycemia. Additionally, four meta-analyses on GDM showed that OADs versus insulin, there was no significant difference seen when it comes to glycemic control. When metformin versus insulin, metformin is associated with less maternal weight gain but higher premature birth rate. In terms of glibenclamide versus insulin, glibenclamide was found to be associated with less maternal hypoglycemia but higher maternal weight gain. There was higher macrosomia, neonatal birth weight, and neonatal hypoglycemia for neonatal outcomes. This table shows the various formulations of metformin available in our country. In GDM, metformin should be offered when blood glucose targets are not met using changes in diet and exercise within 1 to 2 weeks. We need to remember that metformin should be prescribed after consultation with a specialist. Please remember also that it should be continued in women who are already on the treatment before pregnancy. Next, we will talk about the other pharmacotherapy, that is the insulin. We have both human and analog insulin at our disposal. When do we start insulin in mothers with diabetes? Number 1, when blood glucose targets are not met after dietary changes and metformin therapy. We start insulin when metformin is contraindicated or unacceptable. Insulin is also started when fasting plasma glucose is equal or more than 7.0 millimole per liter at diagnosis, with or without metformin therapy. And finally, when the fasting plasma glucose is 6 to 6.9 with complications such as macrosomia or polyhydramnios. In this case, please remember to start insulin immediately with or without metformin. Regarding human insulin, both short-acting and intermediate or long-acting have been established in diabetes in pregnancy. Human insulin is labeled as FDA Pregnancy Category B. In the local setting, human insulin is the preferred choice of insulin in view of its cost and availability. Common examples of said insulin brands are Actrapid and Insulatard. Human insulin counterpart is insulin analogues. Insulin analogues has its own advantages as it mimics natural insulin physiology. Rapid and long-acting or basal insulin analog is currently used in pre-existing diabetes during pregnancy and GDM. For FDA pregnancy category, Category B is applied for insulin lispro and aspart. However, glulisin and glargine fall in pregnancy category C. The common example of insulin analog brands available in health clinics nowadays are Novomix, Basalog, and also glargine. Let me tell you about some interesting facts on insulin analogs. Both rapid and long-acting is as efficacious as human insulin in pre-existing diabetes and GDM. We're already familiar with the fact that insulin analogs are associated with fewer incidences of hypoglycemia. Therefore, long-acting analogs have benefits in diabetic pregnant women with recurrent episodes of nocturnal hypoglycemia. Remember, all insulin are considered safe and have low risk in pregnancy, except for glulisin and glargine. It should be given only when potential benefit outweigh the potential risk. The table below shows different formulations of both human and insulin analogs, their onset of action, peak action, duration of action, and timing of administering the insulin. Click pause to read more about the contents. How do we start the insulin when the values of glucose are abnormal? We start insulin when the fasting plasma glucose is more than 5.3 millimole per liter. Start 0.2 units per kilogram of intermediate acting insulin at bedtime and then increase by 2 units every 3 days until the targets are reached. If the 1 hour postprandial is more than 7.8 or 2 hours postprandial is more than 6.7 millimole per liter, start 6 units of short-acting insulin and then increase by 2 units every 3 days until the targets are reached. If the preprandial short-acting insulin dose exceeds 16 units 3 times a day, consider adding 6 to 10 units intermediate-acting insulin in the morning and titrate accordingly until the targets are achieved. It is recommended that insulin therapy can be initiated at outpatient setting in pregnant women with diabetes. This, however, depends on your local guideline. Always discuss with your FMS regarding this kind of case. The preferred choice of insulin regime in diabetes in pregnancy is multiple daily injections. However, this also depends on case-to-case basis, as we also practice prescribing insulin in separate bolus regime. For example, if a patient's blood sugar profile is deranged on the pre-lunch reading, we will consider starting a bolus insulin before breakfast. On the other hand, if all of the pre-meal glucose are uncontrolled, we may start bolus insulin before all the 3 main meals. If the patient is already using insulin analog prior to pregnancy and has achieved good glucose control, please continue the insulin analogs during the pregnancy. Rapid-acting insulin analog may be considered as an option, particularly in patients with frequent hypoglycemia or postprandial hyperglycemia when using human insulin. How do we monitor blood glucose once patient is diagnosed as GDM? For GDM on diet control, the blood sugar profile or BSP should be performed every 4 weekly. It is done from point of diagnosis till delivery before 40 weeks. Unless there is evidence of fetal complications such as polyhydramnios or macrosomia, which warrants earlier delivery. For GDM on insulin, the BSP is indicated for every 2 weeks till delivery at 38 weeks. The timing of SMBG depends on what mode of treatment the patient is on. If the patient is on diet control or on OAD or single-dose insulin, 4-point SMBG is done to monitor following glucose values: fasting and 2 hours post-breakfast, 2 hours post-lunch, and 2 hours post-dinner. On the other hand, if the patient is on multiple doses of insulin, she should have at least 6-point SMBG to monitor all pre and post meals glucose. What are the targets of blood glucose for the patient? For fasting or preprandial glucose, it should be equal or less than 5.3. For 1 hour after meal, the target is equal or less than 7.8. And for 2 hour post meal, the target should be equal or less than 6.7. Next on our topic is referral of patients. We refer certain patients to secondary or tertiary care. Why do we refer them for shared care? It is for continuous specialist care to detect complications, review medications, and optimize glycemic control if not already. Which patients should be referred? We refer all women with pre-existing diabetes and women with GDM who have poor glycemic control or fetal complications. Referral to a dietitian is also done to ensure a balanced diet, which will help to achieve good glycemic control. Our next topic is pre-eclampsia prophylaxis with regards to diabetes in pregnancy. Studies have shown that pregnant women with pre-existing diabetes have 5-fold increased risk of PE compared to those without diabetes. Regarding studies on pre-eclampsia prophylaxis, a large randomized controlled trial or RCT on women with pre-existing diabetes shows that low-dose aspirin 60 mg is safe but did not reduce the risk of preeclampsia. Low-dose aspirin of 75 to 150 mg daily should be given to prevent preeclampsia in women with pre-existing diabetes from 12 weeks of gestation until term. In 3 multicenter RCT on women with pre-existing diabetes, supplementation of vitamin C and E did not reduce the risk of preeclampsia. There is no evidence to support the use of calcium supplementation in diabetes in pregnancy. Just like in non-pregnant population, it is vital to assess diabetic complications in pregnant women with diabetes. We need to perform retinal assessment as certain patients are at high risk of developing progression of diabetic retinopathy. According to NICE guidelines, pregnant women with pre-existing diabetes should receive retinal assessment at booking. If it's normal, repeat at 28 weeks. If abnormal, refer to the ophthalmologist. What are the factors associated with progression of retinopathy? In a population-based study on pre-existing diabetes, significant factors associated with progression of retinopathy were higher systolic blood pressure during booking, higher HbA1c at first trimester, and greater drop of HbA1c between first and third trimester. So keep it in mind if you encounter these findings in our patients, as they may have risk of worsening diabetic retinopathy during pregnancy. Assessing renal function is also another key part in identifying complications related to GDM. If renal assessment has not been done in the preceding 3 months in women with pre-existing diabetes, arrange it during the first antenatal visit. We also need to consider a referral to a nephrologist if the following is identified. Serum creatinine is abnormal, 120 micromole per liter or more. It's also important to know that the eGFR, or estimated glomerular filtration rate, should not be used during pregnancy, as it is not accurate. The urinary albumin creatinine ratio, or ACR, is more than 30 mg per millimole, and total protein excretion exceeds 0.5 gram per day. Apart from monitoring the diabetic mother, we also need to be alert with the fetal development. The following table shows the fetal surveillance time frame and what structures we need to look for during the scan. From 11 to 14 weeks of gestation, we perform early scan to confirm gestational age with CRL measurement, and we also assess for major structural malformation, including acrania and anencephaly. From 18 to 20 weeks of gestation, try to do a detailed anatomy scan and then look at the structures including spine and heart. And 28 to 36 weeks of gestation, we do serial growth scan every 4 weeks to assess fetal growth and AFI, and the rate of growth can facilitate decisions with treatment and timing and mode of delivery. Next topic lingers around deciding the timing and mode of delivery in diabetes in pregnancy. In two systematic reviews on GDM and pre-existing type 2 DM requiring insulin, they found that active induction of labor at 38 weeks of gestation versus expectant management until 42 weeks reduced the risk of macrosomia, but there was no significant increase in rates of caesarean section, shoulder dystocia, neonatal hypoglycemia, or perinatal deaths. So we can conclude that delivering the baby earlier at 38 weeks reduces the risk of macrosomia. This table shows the timing of delivery according to pre-existing diabetes and GDM. In summary, if the pregnancy has complications or the insulin therapy is started, the delivery is earlier compared to uncomplicated diabetes in pregnancy, or if the patient is on diet control or metformin therapy alone. The mode of delivery should be individualized, taking into consideration the estimated fetal weight and other obstetric factors. Women with diabetes who receive antenatal corticosteroids for fetal lung maturation should have close monitoring of blood glucose levels and the insulin dose adjusted accordingly, as we know that corticosteroids affect blood glucose level. We have come to the final topic of this module, which is postpartum management of diabetes in pregnancy. Regarding postpartum glucose monitoring, for mothers with insulin-treated pre-existing diabetes, we need to reduce insulin immediately after birth. We also advise them to monitor blood glucose levels carefully to establish the appropriate dosing. Most women diagnosed with GDM should be able to discontinue their insulin immediately after delivery. Postnatal period can be dangerous for these patients as they are prone to hypoglycemia, especially during breastfeeding. Therefore, it is important to advise them to have a meal or snack available before or during feeds. In women with history of gestational diabetes mellitus, oral glucose tolerance test or OGTT should be performed at 6 weeks after delivery to detect diabetes and prediabetes. If the result is negative, annual screening should be performed. Metformin and intensive lifestyle intervention during postpartum period should be considered to prevent diabetes. Breastfeeding of at least 3 months or longer should be encouraged to reduce the risk of diabetes. Women with pre-existing diabetes will benefit from preconception care because it reduces the incidence of congenital malformation, preterm delivery, and perinatal mortality. Before conceiving, discuss with the patient on lifestyle modifications, for example, diet, physical activities, smoking cessation, and optimal body weight. NICE guidelines recommend that women with pre-existing diabetes who plan for pregnancy to aim for HbA1c less than 6.5% if this is achievable without causing hypoglycemia. Those with HbA1c more than 10% are advised not to get pregnant because of the higher risks. Apart from that, provide folic acid supplementation at least 3 months prior to conception and perform retinal and renal screening. Regarding medication review prior to conception, women with type 2 diabetes mellitus who are planning a pregnancy should switch from oral antidiabetic agent or OAD to insulin for glycemic control. Patients who are already on metformin may continue treatment. Women with pre-existing diabetes who also have polycystic ovarian syndrome or PCOS may continue metformin for ovulation induction. Prior to conception or upon detection of pregnancy, the following medications should be discontinued: angiotensin converting enzyme inhibitors and angiotensin II receptor blockers, and also statins. Women with pre-existing diabetes are encouraged to have a planned pregnancy. We advocate for patient empowerment when it comes to contraception. However, this should be balanced with any risk factors according to the medical eligibility criteria. There is a delicate balance in maneuvering between what patient wants and what is appropriate according to her health risk. Therefore, informed decision making is important during discussing contraception with patients. Don't be shy to refer to FMS if you are unsure of what type of contraception is suitable for a certain patient. With regards to history of diabetes in pregnancy, the use of oral contraceptive pills is allowed. However, intrauterine contraceptive device or IUCD is the preferred method. Another thing to note is to be cautious when using Depo-Provera since it may worsen glycemic control. And finally, this is the reference list used to create the module. Thank you for joining the module. We are sure that you will benefit from the information given, and hopefully this will aid you in your daily clinical practice. Thank you and goodbye.